Institute, Monash University and the Alfred Hospital. So I'll hand it over to Sharon. Thank you.
Okay, great. Thanks, everyone. Welcome to the Women's Networking Zone. I'm going to ask Sharon some questions about the work she's been doing on The Cure. Francoise was scheduled to join us, but she's been called to another meeting. So what we thought we might do is change the format a little bit and open up the microphone after I've had a bit of a chat with Sharon, and the audience can ask some questions, which I think will be really amazing. So welcome, Sharon. Just from a lay person's point of view, I'd be very interested to hear about the work you've been doing on The Cure and what that means for people living with HIV.
Pleasure to be here, Rebecca. Congratulations for a beautiful space. So I might just start with what scientists mean when they say the word cure, because it means different things to different people. And I think at this meeting we've started to think about that in a slightly different way. And cure currently really means finding a way for people to safely stop their antiretroviral drugs and the virus stays under control. The virus may still be there at very low levels, but under control. And we called that functional cure at the beginning. I think that maybe was confusing for people. And I think with the results from the Mississippi baby recently, a better word is remission. So that how much it's keeping the virus under control but off treatment, or putting the virus in remission. And what we've learnt recently is that remission, generally when people stop treatment, the virus comes back within 1 to 4 weeks. We've learnt from cases like the Mississippi baby that the virus can stay in remission or at very low levels or close to undetectable at all, and the baby was for 27 months. So that, although some people think of the Mississippi baby as a failure or, a disappointment for the field, actually 27 months is an extraordinary amount of time to stay off treatment with the viral load undetectable. So this whole effort is around putting HIV into remission or finding a way to safely stop antiretroviral therapy. So the work that we do is, first of all, trying to understand why the virus persists in people on treatment. And that the main reason is that the virus can go into hiding in long-lived T cells. And as all of you, I'm sure, know, the virus becomes part of the person's DNA. And once it gets inside one of these long-lived cells, it's pretty much there forever. And again, that's what we learned from the Mississippi baby, because we couldn't measure virus in the Mississippi baby, but then 27 months after stopping treatment, it popped back out. And that is classically what you'd expect from a long-lived resting cell that suddenly becomes activated. So the work that my lab does is understanding how it gets into those cells and then how you can pull it out of those cells. And there's different ways that people are trying. One approach is the kick and kill, again, that we've heard a bit about at this meeting. And that means trying to push it out of its hiding place and then kill the infected cell. So it sounds a bit counterintuitive. It sounds like, oh, well, you're going to make my viral load go up or you're going to make me sicker. Well, that's done in someone that's on treatment. So by waking up the virus, any new virus can't go on to infect a new cell, but the virus will become visible to the immune system. So we've been very interested in different drugs that activate the latent virus. And at this meeting, you would have seen lots of stories about the Danish researchers who used a cancer drug, an anti-cancer drug, to wake up the virus. And this is very similar work to what our group did here in Melbourne a couple of years ago and what David Margolis did in the US, except that the first studies of these anti-cancer drugs that I did and David did were with the first generation anti-cancer drug. It was called Burnet. And what we heard about at this conference from the Danish group was a study with sort of the version 3 of these anti-cancer drugs, which we know that are about 1,000 times more potent than the original drug that we use. So what they did, very similar to what we did, they took people that were on treatment, only 6 patients, and many of these studies are only on very small numbers because they're what we call proof of principle, just to see whether what we expect to happen happens, and then you move. If it looks favourable, then you would move on to a much bigger study. So they took 6 patients on treatment, gave them 3 doses of this anti-cancer drug called romidepsin, and then measured whether the virus was woken up from its hiding place. And what they found that was different to what we found was that they found that they could wake up the virus, they could find more virus inside the cell, which is what we found, but they also found more virus in the plasma or in the blood. They could measure it, just like a viral load test. The viral load went from undetectable to 150 and then undetectable again. So that was the big breakthrough, because in the earlier studies that we did, we didn't find much virus outside of the cell. So there was some skepticism that you weren't really waking up the virus. So that's a big part of what we work on. The other ways that people are trying to tackle this problem is by looking at or trying to see, can you induce remission, is through very early treatment. And that's being done. That's exactly what happened with the Mississippi baby who received treatment within 31 hours of birth. And there are some really nice studies of very early treatment in Thailand and now San Francisco. Because if you treat really early, it seems that you have less virus that persists, and it doesn't seem to persist in the very long-lived cells. But early treatment's not going to be a realistic cure, because most people get diagnosed with established HIV infection.
Really excited. As a person living with HIV, I feel like I've got open slather to ask Sharon questions. I'm like super excited. But, we have seen cases of women who have been treated during zero conversion, even here in Melbourne. And then when they go off their antiretrovirals, the virus rebounds. So we're just interested to just tease that out a bit more, because if you wake up the virus and people are on antiretrovirals, what does that mean in terms of longevity for that regime of antiretrovirals? And maybe if you could tease that out a bit more.
Yeah, so in the study, let's just talk about the Danish study, because in that study, out of the 6 patients, I think 3 of them had virus detected in plasma. So there'd been patients that were undetectable for years. They got this anti-cancer drug. Virus became detectable in plasma, so their viral loads became positive, about 100, 150 copies per mil. And then it went back down again, so without any change. And that's because the 6 patients were on effective treatment. So any new virus that was released from the cell actually had nowhere to go. It couldn't go on to infect another cell because the person was on treatment, and then it disappeared. So when we did this study with Burnet in Melbourne for 20 patients 3 years ago, we really weren't sure what would happen if you woke up the virus. Would the virus just go crazy? I think this study shows that we didn't see anything, but in the Danish study they did see it, but it blipped. It came up and then it went back down, which is exactly what you would predict would happen if the person's on effective antiviral therapy, because it's got nowhere to go. It just gets cleared from the plasma.
Wow. I'm just wondering if there's any questions from the audience that people would like to ask Sharon, and take this opportunity while we have a bit of time and space to take questions from the floor.
Hi, Hi Sharon, Heather Ellis. I've been living with HIV for nearly 20 years, and I remember that from the early days, people who didn't develop or get sick from HIV were called non-progressors, and then they were called elite controllers, and at this conference they're now called long-term remission. So does that mean that you're not recognising that some people will never get sick who are HIV, who originally were called elite controllers? And are you doing any sort of scientific research on the DNA or genetic makeup of those people who are elite controllers as a possible source of a cure?
Yeah. No, I think that's a great question, and I can fully understand the confusion. So we know that about 1% of people naturally control the virus without any drugs. They can keep the viral load undetectable, less than 50 copies per mil, and never receive any treatment. And that's exactly what an elite controller is. And that long-term non-progressor was the first word, which again was not getting sick from the virus. And long-term non-progressor was really defined by your T cell count, meaning that your T cells didn't decline without any treatment. And that term was used before viral load actually came available. Then once viral load became available, it became apparent that of the people whose T cells didn't decline, there was a subset who had really low virus, less than 50 copies per mil, no drugs. And we know lots and lots and lots about that group of elite controllers, and it's all about the immune response. Elite controllers make it's all about the genetics of your immune response, and they're able to make a really good response to the virus and keep it under control. So that group of elite controllers have been really informative around vaccine design, because if you can induce those same immune responses, you might protect someone from HIV, and it's a really good way to understand what immune response you need to keep the virus under control. When we talk about long-term remission or post-treatment controllers, it's a little different, because these are people that don't have the right genetics to control their virus. Without treatment, high viral load, if no treatment, they would all get sick. You put them on treatment, viral load disappears, CD4 comes back, doing well, and then you stop treatment. And if you do that in most people, their virus just comes straight back in 1 to 4 weeks. But the goal really of all of this is, could we stop treatment? How do we stop treatment in everyone and keep the virus under control or in remission? Because only 1% of people have the right genetics to keep the virus under control by themselves. Does that make sense? So long-term remission is a term. You're right. Elite controllers are basically in long-term remission. Their viral load stays low. But this is really about the people that have to start treatment, who have a high viral load, go on treatment. They usually can never stop drugs safely. If they stop, the virus comes back. What's that? An elite controller? Yeah. So, and you may have the same virus. There's been some amazing studies. I don't know how you got infected or he got infected, but you could have. There's been some very nice studies of couples who have exactly the same virus, but in one person, in 99% of people, the virus will lead to decline in T cells and disease, and in the 1% of people, that same virus in your partner is completely under control, and that's because of his genetic. He's just lucky, genetically programmed to really control that virus. And we know that there's that variability in lots of different infections.
So the elite controllers are the sort of source of a cure. That's where you're looking at now, the genetics of those elite controllers. Is that the answer?
Yeah, yes and no. That group have really been looked at. It's all in the immune response, not so much in the virus. And so therefore that group have been really informative around designing a vaccine. You're trying to mimic that immune response that 99% of people don't have naturally. And it could be useful in cure. Yeah, it could be useful in cure, except that we've never done very well with a therapeutic vaccine. So when people talk about vaccines, they generally mean a vaccine to prevent you getting infected. But in some infections, you can get infected and then give the vaccine to boost the person's immune response. It's how we treat some rare infections like rabies, for example. You get infected and then you get your rabies shots after you get bitten. And in HIV, that's never worked very well. There's still a lot of interest in it, but a vaccine alone doesn't. Giving a vaccine to someone after they're infected, for some reason, none of the studies have ever really shown that, have ever been shown to work. Though there's still a lot of interest in it.
Thank you, Sharon. That's a lovely segue into my next question. You must have read my mind. But, obviously not everyone here today is a person living with HIV, and some people might be interested to know about the work or the conversations at the conference around the vaccine for people who aren't living with HIV.
Yeah, I think there was a really nice talk this morning, the plenary talk by Antonio Lancevecchia, maybe a little technical for people, but it was he sort of summarised where, a lot of people seem really despondent about 25 years of research and we've got no vaccine. What the hell's going on? What are all those scientists doing with the money? Why don't we have any advances? And I think what he showed was why it's hard, and why some really good insights that we've had that could potentially translate to a vaccine. So out of all of the studies, we've had one vaccine that looks effective but wasn't terribly effective. It reduced the risk of getting HIV by about 30%, which is not great. Usually you want a vaccine to reduce the chance of getting infected by about 70 to 80%. So that was the Thai study, and it was, mixed blessing because it worked, but it wasn't really good enough. And so what he explained was that when you fight an infection, there are two arms of the immune system. You can either make antibodies, like that's what they measure when you have an HIV test, or you can beef up your T cells to respond to the virus. And at different times, people have tried to boost T cells or try to boost antibodies. But the real advance in the last few years is on antibodies. And he explained those today, maybe a bit technical, but he these things called broadly neutralizing antibodies. And these are, some people make a really great response to the virus. They make highly effective antibodies. It's a bit like the elite controllers, actually, that they make highly effective antibodies that seem to respond to all different viruses. So they're perfect for a vaccine. But in those individuals, the antibodies come too late. So the virus is always 2 steps ahead of the antibodies. So what he was explaining was that in the last few years we've had a really major advance in understanding, characterising those antibodies, being able to basically mimic and create them in the laboratory. And now there are studies where people are being given those antibodies to see if it protects them from getting infected. So there's sort of this swing. There are T-cell vaccines and there are antibody vaccines. And he also sort of said we don't really know which one's the better one to go with. But I think he conveyed that there actually has been a lot of progress in understanding the immunology, which has also informed other diseases. He gave examples of how these discoveries in HIV are informing vaccine design for influenza and other vaccines. So I think over the next few, and I sort of hesitate to say this because people have been saying this forever, but these scientifically look very, very good construct, good approaches. But the challenge is once you move them into human studies, whether it's going to work. And the real challenge with vaccine research is to show that a vaccine works, you actually have to give it to thousands of people. So you can't just have, when you're choosing what drug to develop or what vaccine to develop, you might have 3 that look good. In the vaccine world, you can't put all 3 into clinical trials. You've got to choose the winner because because the studies have to be, like that Thai study was about 6,000 people. So these studies are really big, so they're huge investments. So you may just, there's not much room for error there in picking which is going to be the winner. Yeah.
Amazing. For those of you who've just joined us, I'm interviewing Professor Sharon Lewin, who's been doing work on the cure, and we're opening up to the floor for questions from people in the audience. So I will take some more questions for Sharon.
Sorry, thank you so much for coming down. I'm just wondering, it might not be relevant to you, but I've just been learning at the conference the advantages of microbicides. Is that your department, or can you tell me more about them? Because these sound amazing and sound really complementary to treatment. So
Getting back a bit to your question and Rebecca's question about how do you prevent people from getting infected. So we always think vaccine, a shot in the arm, as a baby, you're protected for life. But there's a lot of other ways that you can prevent getting infected with HIV. And that's what we call biomedical prevention. And that's an area of research that's just been very, very productive and some really good results. And one of them is a microbicide, which is a topical gel that can be applied in the vagina or the rectum. And in the gel, people have tried different things. They've tried compounds that block HIV, or they've tried anti-HIV drugs like tenofovir in the gel. And about 3 years ago, a big study came out of South Africa showing that gel, if it was used before and after sex, sort of the timing is kind of quite all related around about the time of sex, you could reduce getting infected by about 60 to 70%. So it worked. And then since that time, there are still more studies to see how effective they'll be. So they're not yet commercially available. They're still being evaluated. I'm not familiar, I don't work directly in this area, but I don't think there's been similar studies amongst gay men showing that you can that you can reduce transmission, but definitely male to female, it definitely reduced transmission. And then in addition to that, but I guess what's happened in the meantime is there's now PrEP, so pre-exposure prophylaxis, taking anti-HIV drugs to prevent you getting infected. The downside of PrEP, though, it doesn't seem to work as well in women as it does in men, and you have to take it every day at the moment, and it's a tablet, and it's a bit of a pain. I mean, women are used to it because they take the pill, but it's a bit of a pain. It's not like just using a topical gel. And then, of course, treatment is prevention. So there's and circumcision, not so relevant. But actually, there's really interesting work here showing that amongst communities, so circumcision has been shown to reduce the risk of a man getting infected by about 70%. And there's a study here that showed that in a community where the circumcision rates go up, you reduce the risk for women. Infections in women go down, which just probably means because you've got less virus circulating. So that was a study that clearly showed circumcision doesn't just benefit men, it benefits women because you're less likely to be exposed.
Okay, hi. My question is sort of going back a bit to what we were talking about before, and I was wondering, with the news about the Mississippi baby, will that change the focus of research, or will... Yeah, that's basically the question.
Yeah, I think it's a very significant finding. I don't think it will change what we do. I think it will change how we design studies and what we call a cure or what we call remission, and how long we monitor people. So to show that someone's in remission, you have to stop antiviral treatment. Because even though we've got really good ways to detect virus that hangs around at really low levels in people on treatment, we can't detect every virus. Because the Mississippi baby, all of the tests were negative on treatment, and then when they stopped, the virus still was negative, couldn't find virus anywhere, and then it popped up. So I think treatment interruptions are going to become part of most of these studies, because even if when you go into your doctor and you have viral load measured, it's one form of the virus called RNA, but we can measure another form that is inside cells. And even when that's negative, it doesn't necessarily tell you you'll be in remission forever. It is really like cancer, So if you've got breast cancer or whatever it is, doctors do their best to cut it out, give radiotherapy, can't find it anywhere. They say, you're looking good, but I'm going to see you every year for 5 years, and you get to 5 years and they say, I'm going to see you every year for life because there's always a chance it will come back. At the moment, we're just beginning, maybe HIV might be like that. And so in the next few, in the studies, I think treatment interruption is going to become more common, and then how frequently you monitor a patient. So on a clinical trial, I think it's going to be very frequent because we don't want people in these cure studies are doing really well on treatment, so you don't want to cause any harm here. So if we stop drugs in the studies, there will be very frequent monitoring. So with the Mississippi baby, the baby never had frequent monitoring because the child was out of care for 5 months and then just turned up. But the other case that actually was the paper was just published yesterday, but many of us have known about this for a long time, is these 2 patients in Boston, and they received a bone marrow transplant, obviously not an option for anyone, but because they had lymphoma. And then all of their tests became negative, so then their doctors stopped treatment and watched them really, really closely. And these 2 patients were in remission for 12 weeks and 32 weeks. So not as good as the Mississippi baby, but much better than the normal 1 to 4 weeks. But while they were being watched, they were being tested twice a week. And then, twice a week is very, very intensive. So that, I think, is going to be part of the strategy. So the cases like the Boston patient and the Mississippi baby have definitely influenced the thinking.
Thanks, Sharon, and thanks for those really terrific questions. I'm just wondering if, very briefly, you could tell us the difference between the work that you're doing and the work that Francoise is doing, or how you're working together on this piece of work and where we fit in Melbourne, Australia, to that picture.
Yeah, so Francoise works in the Pasteur in Paris. She's actually had a long-standing interest in mother-to-child transmission, but in her group a few years ago, they found patients that had started treatment not that early, not like super early, sort of within 3 months of infection. So it's still within that window of what we call acute infection. And they, after about 3 years on treatment, when these patients stopped treatment, the virus didn't come back. And they've got, the original description was of 14 patients. They're called the Visconti cohort. And they're different to, these are not elite controllers because they don't have the same immune profile as elite controllers. So these were 14 patients. They got treatment quite early, treated for 3 years, stopped treatment, and virus is detected but at low levels now for over 10 years. So they're very interesting. That's really where this idea of post-treatment control came in. So the virus is there, you can measure it, but it's at very low levels. And not many people have been able, and she really studies all that. Her group really have studied these patients inside out to try and understand, is it the virus? Did they get infected with some weird virus? Is it they've got immune systems like elite controllers? So that's what she does. Though she's about to retire because in France you have enforced retirement. So she's going to retire from her lab, I think, this year.
Could she move to Melbourne and work with you? I know.
Well, actually, I think they're setting up an institute in Paris, which would suit me much better, so I can go there and she can come here. But I actually haven't collaborated with her directly. I spent some time in Paris working with another woman, Brigitte Autran, and I collaborate a bit with Brigitte. And I've said this a lot, but you've got to, in science and in if really tackling a problem like this, you've got to collaborate really widely. So our group collaborates a lot with groups in the US, and we collaborate with the Danish group that announced their results here, and I'll collaborate with anyone.
We like that. And I guess a question from me as a person living with HIV long term. I mean, I know women lead very complex lives, and another layer added to that is a woman living with HIV. And, many women I talk with talk about how realistic it is to continue taking the antiretrovirals, you know, looking at another 20, 30 years and what that means on our other health issues and our social contexts and how we do that. And I guess not that I'm asking you today for a date of when you're going to find a cure, but, you know, just how realistic it is that women can continue to long-term, day in, day out, take antiretrovirals. You know, it's a challenge for us.
Yeah. Look, I think there's a huge renewed optimism that a cure is possible from the Visconti patients and Mississippi baby, etc. There's certainly increased funding towards the research. There's increased collaboration. It's become like one of the top scientific priorities, not just because we work in the area, but if you look at funding from bodies like the National Institutes of Health that fund research. So I think we're going to hear a lot more about ways that remission can be induced, but a cure for everyone, and that would allow a lot to stop treatment forever. I think we're going to be quite a way off, but there is a really big push now to work on it, which is new. That hasn't been around, wasn't around 5 years ago.
Oh, that's great. I'd like to thank Sharon for coming into the Women's Networking Zone during her busy schedule and talk to us. So thank you, Sharon.
Thank you.